Pause it, please. All right, can you guys see my screen okay?
Yeah.
All right,
Yep.
cool. Awesome, I'm gonna make sure it works. I can't get onto my screen now. So let's do it that way. Hopefully I can play my videos. All right, so let's talk about sepsis. This is kind of a short presentation, a lot of good information. And we can take what we learned with, CPAP, what we've also learned with respiratory system and going into the capnography and pulse oximetry monitoring to kind of get into the sepsis stuff. So today, you'll be able to verbalize your understanding and the criteria for severe sepsis and septic shock. We're going to explain the most common sources of infection for sepsis and explain and demonstrate treatment of severe sepsis and septic shock. They talk about utilizing the 3 and 6 hour bundles. So when I designed this class, I designed it for pre-hospital, but also I did it for the nursing staff at Huggins as well, working with Doug Demers, who's a critical care nurse and paramedic for Huggins. So we kind of did this in conjunction, so I could show pre-hospitally what we're doing when I was working at Huggins in the hospital, working together as one team with sepsis patients. So in a normal response to an infection, the inflammatory and coagulation response is localized to the infection site as the immune system attacks the pathogen, eliminating it from the body. Okay, so we have a known infection site that's here in the picture that you can see. And that's, it's the redness that's around a little bit. Our body is fighting that infection to help eliminate that pathogen from the body. That's what sepsis is. Now, normally when an infection remains localized, you see swelling and redness at the site. The person may or may not have a fever with a localized infection. It does not normally become systemic. When an infection becomes systemic, it becomes sepsis. So this is accepted by the definition of sepsis as the body's overall response to an infection. It also is characterized by coagulation issues such as microemboli and the release of inflammatory mediators. So I have a video here that kind of really describes from Khan Academy on sepsis itself.
When you hear the term sepsis or septic, you might be thinking of sewage. That's actually what comes to my mind, septic tank. And it's not so much that you have sewage in the body, it's more that you have an infection or something that causes inflammation in the bloodstream. Your blood is normally clean and doesn't have any infective material in it, but in septic shock, that's kind of the issue. That's what causes septic shock. Septic shock is shock, decreased tissue perfusion, decreased oxygenation of the tissues, and low blood pressure, hypotension, which is caused by some sort of infection or inflammation. Now, septic shock is really part of a greater category known as sepsis. And I'm going to have to get into some nitty-gritty detail here so you can understand a categorization of septic shock. And really, it's just sepsis is a spectrum. You start with more mild symptoms, and you progress to more severe symptoms. And at the more severe end of this spectrum is septic shock. So let's go ahead and start it out. The first category that fits into this sepsis picture is known as SIRS, S-I-R-S, and that stands for Systemic Inflammatory Response Syndrome. Now, the name of that itself, Systemic Inflammatory Response, suggests that this is in response to something that's inflammatory. Guys, it's in the name, inflammatory response. But it does not necessarily mean that there's an infection. To meet SIRS criteria, a patient must satisfy 2 or more of the 4 following signs or symptoms. First of all, having a temperature above 38 degrees Celsius, so that's 100.5 degrees Fahrenheit, or having a temperature less than 36 degrees Celsius, which is 96.8 degrees Fahrenheit. Now, to give you an idea of what's normal, normal body temperature is 37 degrees Celsius or 98.7 degrees Fahrenheit. So this is about what a patient will have if they have a normal temperature. So being very feverish or being very cold and clammy can be a part of SIRS criteria. The next criteria is a heart rate above 90. Now, notice, normally when you think of a rapid heart rate, tachycardia, which is a fast heartbeat, that's said to be above 100. But for SIRS criteria, it only has to be above 90. Next respiratory rate is above 20, or the PaCO2, the partial pressure of carbon dioxide in the body, is less than 32. So either one of these will satisfy one criteria. So far we have temperature, heart rate, and respiratory rate, rapid breathing, as 3 criteria of SIRS, systemic inflammatory response syndrome. Now really quickly, PaCO2 is normally 40. Less than 32 is because you're breathing rapidly, so you're expelling off carbon dioxide. And of course, a normal respiratory rate is around 12 to 15. The final criteria of SIRS is white blood cells. And if you have greater than 12,000 or less than 4,000, then this meets SIRS criteria. Think of it this way, either your body is responding appropriately and ramping up the amount of white blood cells, immune cells in the body, or more dangerous, whatever infected material, such as maybe bacteria or virus in your body, is winning the battle and there are less white blood cells available. Also, if you see greater than 10% band cell, that can fulfill the criterion also. Band cells are just young immune white blood cells. So the idea is you have a lot of white blood cells that need to be produced rapidly. So the body is trying to create white blood cells quickly, but instead all it has is these young, immature band cells. And so it releases them because better to have something to be able to fight this war against this infection that's going on in the blood. Now remember, these are just really merely clinical clues that could suggest widespread inflammation. I mean, if you go for a jog or go for a run, you already fulfill 2 of these 4 criteria, right? You'll have your heart rate up and your respiratory rate up as well. So really keep it in mind, keep the clinical picture in mind when you're thinking of SIRS criteria. Next on the spectrum is the category sepsis. So sepsis is just SIRS, the systemic inflammatory response syndrome, with a confirmed infection. And sepsis is considered more severe if a patient is showing symptoms of organ problems, organ damage, or organ dysfunction. So for example, a patient who's breathing rapidly and having difficulty breathing could have damaged lung tissue, or a patient with severe abdominal pain might have a bowel perforation or intestinal issue. Or maybe a patient is having low urine output. That shows damage to the kidney. So looking out for organ damage is how you would determine the severity of sepsis. Septic shock is the next step. It's sepsis plus hypotension that just does not go away. And what I mean by it does not go away, I mean the health practitioner is giving fluids and the hypotension still is not going away. And I want to make a point here. Adequate fluid repletion is 30 milliliters per kilogram. So you take the patient's weight into account. So for example, a patient who weighs 50 kilograms, you would give 1,500 milliliters as quickly as possible. And if the blood pressure does not go up with this fluid challenge, then the patient is in shock. Last of all, on the most severe end of sepsis, of the sepsis spectrum, is MODS. This stands for multiple organ dysfunction syndrome. Multiple organ dysfunction syndrome is when a patient has severe septic shock with organ failure. Now I know that I said at the more severe end of sepsis, I said there would be organ dysfunction. You'd have difficulty breathing, gastrointestinal ischemia, decreased oxygenation of the intestines, causing GI perforations, and maybe kidney damage as well, causing decreased urination. But a lot of times in severe sepsis, this organ dysfunction can be recovered. In MODS, it's essentially beyond the state of being able to recover. And also in multi-organ dysfunction syndrome, the liver begins to fail. And if the liver begins to fail, it cannot clear out toxins that the body has. So the infective material, the bacteria, or whatever infection is in the blood can no longer be cleared out effectively by the liver. And the body just completely shuts down. And so with sepsis, you want to catch it as early as possible so that it does not progress to more severe septic shock or multi-organ dysfunction syndrome.
All right. So with that being said, sepsis is a major worldwide healthcare problem. So it's affecting an estimated 30 million adults and children each year, resulting in potentially 6 million deaths annually, which accounts for 20% of the U.S. hospital admissions, but is also a factor in over 50% of the U.S. hospital deaths and is a leading cause of U.S. hospital readmissions by 20%. And that is where community care medicine comes into play with that, to prevent that readmission status. Although mortality has decreased in the last decade, it still remains over 25%, which is 1 in 4 patients. So the inflammatory and coagulation response is a rapid, widespread, causing a dysregulated response. So the body's reaction to the pathogen may overwhelm all the body systems, as you can see here in the bottom picture, going into organ dysfunction and then death. And the immune system that are too strong or too weak are unable to respond effectively to the pathogen invasion. So what's happening is your infection is really, a source of infection is getting bacteria into the blood, and so they call it bacteremia. What happens then is the blood cells become very leaky, so they start leaking out the infection, then for causing organ dysfunction, which then can lead into death. We want to prevent this from happening at the source of the infection. We want to be able to find this source and try to treat it. That's why they give usually 2 different types of antibiotics in these patients in the ERs. So the cause of sepsis obviously is a bacterial infection, which are the most common. Fungal, parasitic, or a viral infection can also cause sepsis as well. So the infection can originate from anywhere in the body and can cause organ damage to any system in the body. Like even like a gastroenteritis can turn into sepsis from the infection that's in there, depending on how it gets into your system. Unknown 1/3 of all sepsis causes of how they become septic. One of the biggest ones that we see, though, usually for sepsis, it's hospital acquired, is going to be your pneumonia patients that turn septic. So some common infections can lead to sepsis among adults with sepsis. They had a lung infection, pneumonia, or UTI, kidney infection, where you're turning to urosepsis. That's a gut infection, so maybe like a gastroenteritis, an infection like that, or a type of skin infection. But as you can see, 35% of this was pneumonia, which is the most common infection sources. Some of the host factors obviously would be age, gender, and genetics or comorbidities. The elderly account for 60-85% of all cases of severe sepsis, right? And this is when you're working in the emergency department. This is what we saw a lot of was people over 60 years old. That's it's more than the accurate number, 60 plus. But we saw a higher chance a patient to develop a septic reaction to something. Immunosuppression, disease-related, medications-related as well, or exposure risk, was community-acquired pneumonia, urinary wounds, trauma. Healthcare-acquired invasive devices, secondary infections, and skin breakdown. So that's why they move patients quite often up in like the medical units to get so they don't have that skin breakdown. They lotion the skin, they wash, they clean, change out sheets, have more comfortable beds, so they don't start developing any kind of sores. There's a lot of things that go into play with this. So the progression of sepsis, obviously early identification and treatment is crucial to identify, to avoid developing organ damage and shock. So this is what we're looking for in the field. This is pre-hospital. We want to find out first if they have a temp of greater than 100.4 or less than 96.8, a heart rate of greater than 90, respiratory rate greater than 20, and an end tidal less than 32, and a MAP of less than 64. If you have 2 or more of these, that's considered severe inflammatory response syndrome. Okay. Now, you have 2 or more SARS plus a known or presumed infection site. Now you have sepsis. Severe sepsis is sepsis with hypotension, and septic shock is hypotension refractory to fluids of 2,000 milliliters. All right. If you have patients in septic shock, or we start seeing severe sepsis, we need to start thinking about giving vasopressors, right? Levothed, and getting these patients on vasopressors to fix that hypotension, right? If we can't fix that, multiple organ dysfunction syndrome will start kicking into play, and then you'll start seeing death. Or they'll start developing DIC, which they have an overproduction of clots throughout the entire body, causing patients to actually have amputation or limbs removed because of the DIC and completely blocking your arteries and everything else, excuse me, through the system. SIRS can be defined as 2 or more of the following, which is just systemic inflammatory response syndrome, a body temperature of greater than 36 Celsius, or less than 36 Celsius or greater than 38 Celsius. Cold sepsis is very bad, right? That's worse than having a temperature because now your body's no longer fighting off that infection. Heart rate of greater than 90 beats a minute. All right, white blood cell count of greater than 12 or less than 4. So where do you think that your immunocompromised patients sit for a white blood cell count? You think they'll be high or low? Patients receiving chemo.
Low?
Low, yeah, exactly. So when you're taking these patients from hospital to hospital, this is why it's so important to review their lab work and document this. And for people that have seen my run reports, you notice I put down my lab values and everything else with the normal limits or what's off, right? Because you got a patient that has a white count of 2.2, they are very prone to getting an infection. And the problem is their body can no longer fight it off. All right. Respiratory rate of greater than 20 breaths per minute or a PaCO2 of less than 32. So get these end tidal on these patients and look at the numbers, right? Respiratory rate greater than 20. If they got respiratory rate of 22 to 24, it's considered an inflammatory response syndrome, right? So 2 of these plus infection equals sepsis. Then severe sepsis obviously was plus new organ dysfunction. Phrase that again. Sepsis plus new organ dysfunction equals severe sepsis. So would that be a GCS of less than 12? Are they altered? Respiratory, new BiPAP, mechanical, and ventilation. Metabolic or hepatic, lactic level of greater than 2. We usually use 4 as a number. Now in the pre-hospital field, it used to be 4. They've gone down to like greater than 2 now. So 2.1, 2.2, or whatever is still considered an elevated lactic level. Platelet counts of 1,000 or INR of greater or less than 100,000 or an INR greater than 1.5. So look at your lab values for those. Usually when they run a PT, they run a PT INR. With that, your cardiovascular stuff is systolic blood pressure less than 90 or a MAP of less than 65. Right? Systolic drop of greater than 40. So you want to make sure you're repeating your vital signs in these patients as well. And then also urine output of 0.5 mLs per kilogram per hour. So the average adult urine output should be 30 mLs an hour urine output is on average, okay? If we're not seeing that, we're not seeing urine production, we've now had organ dysfunction and we're starting to see renal system, kidneys starting to shut down. Okay, that's really bad if we're pumping in liters upon liters of fluid with no output. Okay, so we have to kind of keep that stuff in mind. So when you're doing your inter-facility transport, the patient's on Levophed, they're septic shock, they're intubated, Foley's in place. I want to know how much fluid has gone in, that's your ins, and how much fluid has come out when they first put the Foley in place. Okay, and if they've done a bladder scan, a lot of times they do bladder scans to see what kind of fluid is still inside the bladder. Ask them for a printout of the bladder scan. They have it printed out, right? So you can get that. You want to find out how much fluid was actually in the bladder, how much came out when they placed the Foley. If nothing came out and they're that dehydrated, that's a problem, right? And you're going to start seeing changes in kidney function. And what are the two lab values that really indicate, well, we'll say two lab values and the third one, which would be your GFR. What other two lab values would you see increased in patients that have a decreased kidney function? Or these are more towards the medics.
BUN?
Correct. Your BUN, and then what's the other one?
I don't remember the other one.
It's okay, creatinine. So you have
Creatinine.
a BUN, elevated creatinine, elevated BUN, and you'll find that on your CBC, okay, your comprehensive metabolic panel. So you look at your CBCs, and you'll look at that. You look for your BUN and creatinine levels on that. Okay, your CMP also has your LFTs, your liver function stuff as well. But really, what I'm looking for in this is this patient in acute kidney failure because of this. So we're going to look at our elevated BUN, elevated creatinine, and by elevated those, it'll actually drop your GFR to the point where they can't even get scans because now our body's no longer filtrating, right? So the normal GFR is greater than 60, right? 50 is not horrible. You start getting into the 40s and 30s, they no longer can filtrate, even the contrast die out. That's why patients don't get CTAs with GFRs of less than like 45, all right? This is more towards the interfacility stuff, but these are all things that you should know about before you take your patient to find out if they are in kidney failure or not. Because the nurse may not present that to you. So read the discharge paperwork and always look at the lab work as well. Because if I have an elevated lactic, an elevated white count, let's say at 30, okay, which is really high for a patient, okay, they're intubated, they have an elevated BUN, elevated creatinine, I know they're in kidney failure, right? And I'm going to look at this as I'm treating my patient throughout transport, you know what I mean? So that's the things you want to look for in your septic patients. Cultures, they're not going to be back yet. They take days to come back. So don't worry about even looking at the culture results, right? Unless you're taking something out of the ICU and they've been there for like a week or so, then you can ask for the cultures. But then if it's something more acute coming out of the ER or within the last 24 hours, they may not have enough cultures back. Look at their urine if they had any urine made at all, and look at the urinalysis and see if they have any kind of bacteria, ketones, blood release, or anything like that at all. That could all indicate potential for any kind of UTI, and they could be like a urosepsis that caused this as well. So now if you had a patient in septic shock, lactic greater than 4, this is a patient that has severe sepsis, refractory to hypotension, or lactic greater than 4. Septic shock is a distributive type shock, which is cytokine release leads to a large-scale inflammatory response. So massive full-scale vasodilation of the body, which then increased capillary permeability. That's when you started seeing that leaking out. Decreased systemic vascular resistance, blood clots start forming in microvasculature, that's more of your DIC, and then your hypotension reduces tissue perfusion, causing tissue hypoxia. These patients that are in septic shock need pressors, okay? They need Levophed. Levophed is the pressor of choice for these patients. Then we have MODS, which is multiple organ dysfunction syndrome, where we saw respiratory, liver, kidney, and heart failure, gut permeability, DIC, disseminated intravascular coagulation, brain death, and altered mental status, right? Sepsis-related organ dysfunction or no organ system is immune to any of this stuff at all. So any of this can happen. Our treatment protocols for sepsis obviously is going to be utilizing at the EMT level. If positive sepsis, notify the facility coming in. Rapidly administer 30 mLs per kilo. So remember, for AEMTs, you have to do math for this. We don't want to give them, there really there's never too much fluid you can give. But 30 mLs per kilo. How to convert? Take the patient's body weight, divide it by 2, and take off 10%. Right? So if it's 150 pounds, half of 150 would be what? 75. Okay? 75 minus 7, your first number is your 10%. So it'd be 60, was it 68? 69, 70, yeah. So 68 kilos. And we'll take that, multiply that by 30, and that'll give us a total bolus amount, right? So down and dirty math, unless you have a calculator handy, you can do body weight divided by 2.2. At the paramedic level, we can do push dose epi by diluting. Boluses, prepare 10 ml, 10 mics per ml, adding 1 ml of 0.1 milligram of ml of epinephrine to 9 mLs of normal saline. Administer 10 to 20 mic boluses, which is 1 to 2 mLs every 2 minutes, where feasible. Switch to infusion as soon as practical. You can do an epi infusion of 2 to 10 mics per minute via pump, or a norepi drip from 1 to 30. I usually start around 5, and I work my way up from there, or down depending on where we need to titrate to make the effect that we're looking for. Continue fluid maintenance and pressor administration, and titrate to a math of 65 and systolic blood pressure of greater than 90. So as medics, we can do push dose epi to start, and then we can switch over to a levothyroxine drip. So if you have 2 medics out back, it's easier to prep the push dose epi, so you can push your first dose and then set up your levothyroxine drip and get that running, or your epi drip, depending on which one you want to utilize. To make the epi drip, we just take the 1 to 1,000, the full vial, put it into a 1,000 bag, and we can set up our drip for mics per minute. All right. This is why it's so important to have pumps available to you and making sure that we're giving these medications. If we walk into a home or a nursing home, the patient's already in septic shock, we need to start treating now. Because the longer we wait, the higher chance this patient's not going to come back out of this, right? And since we don't carry first-line antibiotics, so we don't carry ISTATs on the ambulance, we can't start Rocephin or anything like that at all to start the antibiotic treatment. But before you can even give an antibiotic in the field, you have to be able to draw your labs prior to and your cultures. Once you start giving antibiotics, at that point, it's too late. Sepsis pediatric protocols, obviously a finger stick lactic level if available, which we don't carry finger stick ones at all, because the state, which I did check with at this current time, do not allow the glucometer style lactic meters. It has to be an ISTAT. Those things are not cheap. And this is pediatric protocol. All right, so advanced care. New Hampshire does have an advanced sepsis protocol that allows us to give a first-round antibiotic if you meet the criteria. You have to be in severe sepsis or septic shock criteria, no allergies to any available antibiotics. Normally, we're going to see ceftriaxone or Rocephin on the trucks. They're not going to give us Vanco or Zosyn because those have to be IV pump infused, and they have to go over an hour to an hour and a half, depending on the infusion and how much is being given. With ceftriaxone, usually it's 1 usually it's 1 gram. With that being said, that can be given over 20 minutes, 15 minutes through an IV drip. Right, and sometimes those don't even have to be pump infused. I mean, I'd recommend it, but they don't have to be. But prior to that, you have to draw your tube, your colors, so blue, purple, yellow, and green. Draw a red tube while you're at it as well. Just get all your labs done. Then you have to draw cultures ×2. And what they mean by cultures ×2 is you have to draw 2 sets of cultures. But they have to be from different sites. You have to get 2 lines, 2 sets of cultures as well. Any patient that is septic, get 2 lines in while you can. Because once they start vasoconstricting, because they start shunting because they're in shock, it's going to be harder to find line access. So if you can get 2 lines in, get 2 in and help out the nursing staff in the hospital. All right. Also, if you're running an antibiotic, you cannot run an antibiotic with a different medication. They have to be in their own line. and we never run 2 antibiotics at the same time as well. Even if you're taking interfacility transport, no, I'm rephrase that. You can take 2 antibiotics in interfacility transport. You cannot initiate an antibiotic during the transport of all those. All right. So as far as the treatment bundles go, this is more of the hospital side of stuff. Again, I'll kind of go through this pretty quickly. They're going to draw a lactic. The reason why we don't draw lactics in the field is because they have to be on ice. And they're only good for 15 minutes, so they have to get to the lab. We're going to do cultures ×2 before giving antibiotics. We're going to give ceftriaxone, Zosyn, or Vanco. We're going to do a 30 ml per kilo fluid, initial hypertension, lactic greater than 4, septic shock, reperfusion assessments. They have to do this within the first hour. They start getting the sepsis criteria done. All right, so why 2 sets of cultures? The corroboration of matching sets confirms treatment of a true pathogen versus a contaminant. Antibiotics are life-saving treatments for an infection. This is why antibiotics are so important to be given. Every hour antibiotic initiation is delayed increases the risk of mortality by 4 to 8%. That's a lot. Okay, so that's why antibiotics need to be given so quickly. That's why we have an advanced sepsis protocol if we have the ability to measure lactic acid. And ISTATs are the way to go for those. The most important thing you can do for your septic patient is antibiotics. As you can see, an hour delay of antibiotic administration increases mortality rate. So quickly get the first round of antibiotics in. Society of Critical Care Medicine suggests isotonic saline, normal saline, or a balanced salt solution like lactated ringers for initial fluid resuscitation. Right? So if you carry ringers on your truck, there's nothing wrong with starting your first bolus as ringers and then switching it over. Right? Because it helps build that electrolyte imbalance that they may have. But if you can get labs prior to giving electrolytes, that's a good thing because they want to be able to check those before we start flooding them with fluids. So if your facility has labs to be able to be pulled, draw a rainbow set before administering fluids. This is your lactic stuff for mortality rate. So if you pull a lactic and it's greater than 4, you have a 28.4% mortality rate. The first sepsis bundle is time 0 or time of presentation is defined as the earliest chart documentation consistent with all elements of severe sepsis or septic shock identified through chart review. So we look at the pre-hospital stuff as well, looking at Sears criteria and organ dysfunction. Severe sepsis, we talked about earlier, to be completed within 3 hours. They have to draw a lactic. They have to do 2 blood cultures, administration of broad spectrum antibiotics, and fluid resuscitation of 30 mL per kilo with a crystalloid solution, so NS or LR, to maintain a blood pressure of 90 and a MAP of 65. They're going to do repeat lactics as well. Another thing they're also doing too is a procalcitonin level, and you're seeing what they call a procal check. And they do those for patients that have a respiratory sepsis. So like they have pneumonia, they'll pull a procal level as well. Some other documentation of tissue perfusion reassessment provided documentation of 5 to 8 of the following. Arterial oxygenation, so usually respiratory will come in, they'll pull a blood gas on them. Vital signs, cardiopulmonary exam, cap refill, peripheral pulse evaluation, skin exam, shock index, and then a urine output. All right. So how do we measure shock index? You guys know how to check that? So it's the
Systolic blood pressure minus heart rate,
so it's
or vice versa. Or
you got those 2 correct. So it's going to be your heart rate divided by your systolic blood pressure. Okay, so heart rate divided by systolic blood pressure gives you a shock index. And the shock index also is very important because we're talking about RSI as well. That's one of your things you need to multiply or figure out as well with RSI is the shock index of the patient. Provider document, so obviously CVP or central venous oxygen measurement as well. Bedside cardiovascular ultrasounds and result in passive leg raise or fluid challenges as well. So anything we do for the patient. Provided documentation for completion of perfusion reassessment as well. So why do I talk about this? Because when you take a patient out of the emergency department for interfacility transport, they've already started this process, the bundles. Okay, so ask them about it. What have you done so far for sepsis treatment, right? If they're doing elevated legs, then we continue that treatment for them. We can put them in the Trendelenburg position, right? We got to find out what the treatments have been done, document what they've done, and how we're going to continue that through our interfacility transport. So to really have 3 hours, you know what I mean? So after looking at this slide here, 5,000 patients with severe subseptic shock. Majority of the patients had 4 3-hour bundle recommendations issued within 3 hours, and the in-hospital mortality was 27.8%. The time after which a delay increased the risk of death: lactic 20 minutes, blood cultures 50 minutes, antibiotics 125 minutes, crystalloids 100 minutes. Labs do not come back very fast. Okay, lactics can take sometimes up to an hour depending on how busy the lab is. They do not put rushes on labs. They come in, they do them in order, and they come in when they can. All right, so things to think about. That's why it's so important. If you can get labs in the field and give them to the ER staff, they can send them right away. Okay, that's why it's important because the time frame just takes so long to get that to work in the ERs. All right, so remember that signs and symptoms of sepsis signs and symptoms are highly variable due to abnormal dysregulated response. And the most common response to infection is fever, although not everybody has one. Even with uroseptic patients, they may not have a fever and still have an infection. They may just have altered mental status. All right. So what do you guys think of the sepsis? Did that make sense to you guys? Was it worth it?
Good lecture.
Yeah, it was good.
Awesome.
Good. When are we getting iStats for the trucks?
I would love Maine Medical Center to give us iStats because I know that we can't afford them. I think we should have them on the 911 medic trucks, and I think we should definitely have them on the interfacility truck to monitor labs as we're doing our transfers. That will help us determine vent settings and a lot of other stuff too in different treatments. So that is all I have for you now. I have a orientation starting at 1. So we will reconvene this stuff in a couple weeks. And I'm hoping that you guys are enjoying this. Please feel free to jump in. They want us to have a minimum of 6 students per class in order to keep this running. Now, my days are not going to be this long every single time. Okay, so I'm not going to run these for like 8 hours a day. But we'll do, once we get the NCCP done, we'll go back to doing a 2-hour lecture once a week. So I'm hoping that we can continue this. The goal is 6. If it's less than 6, they want me to cancel it. So please, if you're at home, get online. They love the education, but they also have to be justified to pay for as well.